And I wonder if you and or the panelists can speak a little bit to this issue, which is Gons, as you said, had this paper early 1990s, late 1988, like late 1980s, 1990s, early 1990s, 3 decades ago, basically. And subsequent to that, you talk about this thousands of papers and this increasing number with 400 papers in the last year or so. Have we, in the last 3,000 some odd papers, made a serious impact in terms of knowledge? Or are we now getting into the optics that FAI is a hugely important area, lots of people are engaged, and we're starting to get into noise? And then how do you get to signal versus noise? And I think this happens a lot with areas where they see a very strong surge in popularity. The evidence doesn't always correlate with the popularity. And I'm curious, as thoughtful individuals who have thought about this process, where are we with this? Like, why suddenly did we see this big shift? And ultimately, this massive amount of literature that's happened now, is it of the quality you need? And I think I know some of the answers, but I'm just curious to get your take on it.
I think, Mo, you probably know all the answers. Yeah, I mean, certainly the data that we are looking at and the quality of evidence we are producing is nowhere near where it needs to be in arthroscopic intervention, or even for that matter, open intervention for FAI, because there are just so many variables. And as soon as you know a bit more, you suddenly are opening up 3 more variables which are going to affect your outcome. So I think we are certainly understanding a lot more about the disease process. I certainly have changed my practice almost completely differently to what I used to do even 5 years ago. And it's been a journey. And I think along the way, we've got some good evidence. I wouldn't say all good evidence, but some good evidence. But probably registries are the future, and embedding trials in these registries where you've got multiple surgeons contributing to these registries are potentially the future. So we are still away from what trauma has been able to demonstrate in their trials. But I'll obviously take Nico's and Oliver's and Thanos's view on this as well. What do they think in their respective countries?
I'll start to talk if you want, Vikas. Thank you for this always great talk, as you know how to do it. You're totally right. And the more you know, the less you know. It's terrible. There are so many variables that it's just a big mess. And yeah, we need some more evidence, but it's really difficult to conduct correctly. And
well, I mean, so here's my point, Nico. The point is that, if someone said to you there are 400 papers last year focusing on FAI, and when you talk to experts like yourself and thoughtful individuals, surely you would say, okay, we've made a big advance, right? We made a big advance. My perception is when I look at hip fracture literature and a bunch of other places where there's been lots and lots of work in the area, but major advances have been few and far between. That's the gap, right? That's always the gap. And I'm curious, if there are major advances, what do you think they are? Like what with all, if there's 400 papers last year, which one should our members read? What should we be focusing on? Vikas, you did a great job in giving us this overview, but maybe the panelists could speak to that issue.
I was going to add that we're at a stage now that I think that our surgical skill and technology is evolving faster than our actual knowledge is. They're not going hand to hand. We're doing more stuff, but with less evidence. So we need to balance that as time goes by. And as Vikas said, expert opinion and the registries are going to give more answers. It was quite interesting because all of us, Oliver, Vikas, Nick, we were at a panel over the weekend, tried to exactly answer to all these questions. There were 50 surgeons from around the world, and I have to say that there was not great agreement between us, even on basic stuff, even now. So I think that's where we are. We need to get better science and possibly try to evolve them at the same pace. I don't know if that's possible.
I agree with your comments, but actually, I think we are flying around the diagnosis and the correct indication and the surgical treatment, because in the last years, we are operating different diagnoses, I think. And actually, we are trying to define what are we doing and in which cases, and be very precise with the treatment and the diagnosis. I think that's the reason, because we have hundreds of papers, because we are talking about different things, and now we are going to the point that we have to do.
So maybe a question. I mean, if anyone has a question, please do just, oh, okay, I see a question. Sepper?
Yeah, hi, Dr.
Okay.
Khanduja. Good to see you, and thanks for a great talk. As you and I have discussed before, in Canada, it's not necessarily the norm that the same surgeons who are doing hip arthroscopy are doing hip arthroplasty. There are some obviously notable exceptions, but this is not typically the norm. And so I'm curious, obviously part of the whole evidence-based medicine paradigm is individual patient preferences and circumstances. I'm curious, with your experience of doing the whole continuum of hip surgery, what has the evidence, what kind of insights has the evidence given you in terms of determining for a given patient, and typically I know your patients tend to be more active than average probably. How do you have that discussion with them about, the potential benefits of hip arthroscopy versus hip arthroplasty in an individual patient setting?
That's a very good question, Sepper, and it lends itself very nicely to a randomized controlled trial, which we are actually working on. So clearly, there is no doubt in my mind that if you have grade 1 up to grade 1, torus grade 1 and arthritic change and FAI, surgical intervention would be a good option for you. The problem arises if you've got tonus 2 stroke tonus 3, whether you're going to be, and you're 35 or 38 or 40, whether you're going to be better off with the resurfacing or a total hip arthroplasty, a short stem or whatever you may decide to choose, or a hip arthroscopy. And the answer is we don't know, okay? There are so many variables for that particular, young adult male who's very fit, who wants to go ahead and continue playing five-a-side football at least over the weekend. And he's coming in with tonus 2 stroke 3 with a large cam lesion. Should you give him an arthroscopy, or is he going to be better off with a resurfacing or a total hip arthroplasty? Answer is I don't know. And that's exactly the discussion that I'll have with him. Anecdotally, we've operated on these patients in terms of a hip arthroscopy in the past, and they've done well. And equally, there are patients who've not done so well and have actually progressed onto having arthritic change fairly quickly and having a hip replacement. So don't know is the real answer. That's a real dilemma. So that lends itself to a very nice randomized controlled trial there, very well controlled trial. And that's what I said, the FATE2 trial is that's what it's going to be looking at. But it'll be good to hear what Oliver and Nico have thoughts on this as well. Oliver, you're going to say something.
Yeah. I agree completely with what you said, but the problem is what I told before. Sometimes you are saying that the patient is tennis 2 and is very young, but if you do, as you mentioned, because a false profile or any other view in the CT, you can see that there is more damage of the cartilage than you think before. And this is the reason because some patients fail. So you have to assess perfectly what is the damage of the cartilage in that patient and explain the patient the real success of this hip arthroscopy. I think that's the problem.
And how do you define success as well, Seppa, right? Is your success based on you walking 12 steps without pain, or is your success based on playing a football game for 45 minutes without pain? So that again is an issue, right? The IHOT 12 just clubs it to 12 questions. And if you've got an MCID of 12 points or over, then it's successful, sort of successful. But what is success, right? And in this young adult population, which is what Sunil's PhD is defining what is the right way to actually measure the outcomes in these individuals. Probably you can weigh in on that, Sunil, and tell us your thoughts on that.
Exactly. Thanks very much, Ms. Khanduja. It's a lovely talk. In terms of what we assess patients or patient-reported outcome measures are quite important, but there are several of them. And if you look at the literature, there are, they're not the same, and you can't compare the two results. So if you look at the two RCTs we've had in the UK, the FATE and the Fashion, they've used different outcome measures. So you can't, if I want to do a systematic review, it's very difficult for me to club the results of just these two. So if there are more systematic reviews as well, and they're using different outcome measures, we can't have a meta-analysis. And what I'm looking at is, what is the best set of outcome measures that we should use in a way that's the standard for every randomized controlled trial in the future, so that we can compare trials and have a meaningful result with a large data set. And that's what I'll be looking at. And we've done a few systematic reviews over the last couple of years, and most of the evidence is level 4, and they've used different outcome measures. So that is the biggest issue that I've found.
Mo,
Can I ask? Oh, go ahead.
Yeah, I was going to flip it on to you, Mo. You've obviously looked at a lot of data. You are the king of analytics, and you're obviously looking at all these mad guys publishing 460 papers, too much of noise. What do you think is the way forward? Publishing a thick book on evidence-based medicine.
Yeah. So I was actually going to ask the question back to you, which is funny. You would think I'd be focused only on the RCT, and my question actually was that when I think about some of the randomized trials that have been done in the area of FAI, and I was involved with Dr. Femi Ayeni, as I think many of you know probably, who was involved as one of the lead investigators in the first trial that was, looking at, lavage, a labral repair, and or the, osteochondroplasty, randomizing to that or not getting it, but plus or minus the labral repair. I often wondered if some of these trials, even if, because these aren't thousands and thousands of patients, are the randomized trials in some way, because they're so strongly believed, are they in some ways a hindrance right now in this rapidly evolving, area that is, FAI and the research around it? I think it was Nico, you had said that, there's lots and lots of databases. Vikas, you've talked about registries being really important and expert opinion as from the innovative side being important. My question back to this group is, when you look at the randomized trials that have been published, have they been more helpful, or have they been more of a hindrance to moving forward? Because sometimes when someone shows a small randomized trial that says no difference, it has the potential of just completely shutting down debate or shutting down the opportunity. And then you have the individuals who are entrenched in the FAI world saying that trial is not representative of the patients we see and the issues that are at hand. It's very complex. We have lots of papers being published with multiple indications, and we're trying to sort it out. And this trial that just says FAI patients, surgery versus no surgery, doesn't have an impact, puts us back a few steps because we know we have to go forward. And I guess that's my question. What is that debate like from individuals who really believe it works? And when you see a trial that says it doesn't, do you take that sigh and say, we have to go, and now we have to spend lots of hours and time to sort this out because the trial didn't quite get it right?
Means I can say from a personal point of view, this Fashion and FATE confirmed the belief that there is a set cohort of patients which will do well with surgical intervention. First had so many issues with it that actually didn't impact my personal clinical practice. So I've continued despite first. That's what I'd say. And therefore, I just feel that randomized controlled trials in this arena may not be the only answer. And therefore, we need to look at registries and probably therefore international registries, large cohort of patients coming in. But more importantly, I'm stressing on this, that we need stratification of disease, and we need to classify preoperatively our patients better. So all of us around the world know we are talking about the same thing. At the moment, we are not comparing the two, same like Oliver was saying. we're comparing oranges and apples because we still are not classifying and stratifying these patients correctly. So first was not a hindrance to me because of the issues that it had. Fate and fashion certainly confirmed the belief that we can make some of these patients better. But equally, as you could see, two of the PhDs working on muscle strength and prehabilitation, First and Fate also showed that physiotherapy and working on the muscles may have a larger role than we surgeons actually think. So we need to pay more attention to that as well.
Got it. And is there anyone else with any thoughts on that particular broader issue about randomized trials versus non-randomized trials as you think about trying to get to the right answers? Looks like they all agree with us, or you, Vikas, so that's good.
No, Nico was going to say something.
Oh, go ahead, Nico.
It's very difficult because we really want to make an evidence-based medicine and to make it totally categorized and say, okay, this doesn't work to you. But something that works 40% of people, if you're in the 40%, it's 100% for you. So it's always a balance between what could be done. We were talking about somebody that is 25 or 30 that has a Tony's 2 grade arthritis. 20, would you put him, if you have 50% chance of putting back to sports, he will take it, So are we computers saying this doesn't work, we won't do that to you? Or are we just human and thinking, okay, for 50% chance, you are 25, I will try it to me.
You make such a great point because, when we talk about the area of, let's say, fracture care, non-union, to go into a non-union surgery is a big deal, right? For surgeons as well as a big deal for patients. So when you say to somebody, hey, we have something that might work 2 times out of 10, 3 times out of 10, 4 times out of 10, and it's limited invasiveness versus the big surgery, you will 100% of the time have endorsement by the patient, right? As long as that there's an economic, the cost of it makes sense, it's cost effective, et cetera, et cetera. But great point. I mean, the downside, it would seem to me, of having surgery, if there is a downside, is maybe a delay in terms of if it doesn't work to have to go and have something else done. But boy, oh boy, you make a compelling argument, Nico, around the idea of patients' values and preferences, which is one of the central tenets of EBM, right? We begin and end with the patient. The patients need to be informed about what they need to do. That gets to my other broader question, just more of a general question for not everyone who may be an expert in the area, but is interested in trying to understand the issues. There are the soft tissue issues, which is the labral issues, and then there's the bony issues. When we think about what's happened in the knee, for example, there's been lots of debate, right? You do the bony corrections and they have a major impact. And then you do, when you look at the, the meniscal debridements, they don't seem to have an impact. At least the evidence would suggest, it doesn't really matter about the meniscus as much as it matters about, the actual alignment correction, the bony issues. Is the same true in FAI, or does the repair of a labrum lead to a dramatic and definable effect that is uniquely different from what happens often in the knee OA patient?
So from the work that we've done with the discrete element analysis, there's no doubt that if you are able to excise the CAM lesion, this is specifically for CAM, you actually neutralize the peak forces at the anterior edge of the acetabulum. So that's for definite.
Right.
And if you didn't take the CAM lesion off, those forces are still going to be there. The question to my mind is, you can see a 70-year-old with a large CAM lesion and not a lot of arthritic change with the same amount of peak forces. And then you see a 23-year-old guy with the same CAM lesion and who's already developed arthritic change. So in which patients this CAM lesion is going to produce the arthritic change or has the ability to produce the arthritic change is what I think the question is. So whether it's genetics or whether it's your activity, which is actually playing a role in it, who knows? But clearly taking that CAM lesion off will neutralize your forces.
So to get that question answered, given how popular the rising popularity and awareness of FEI, where can you actually answer that sort of natural history question right now? People always talk about, well, what happens with an ACL over time, and does it lead to, degenerative changes? And in most cases, ACLs are treated fairly aggressively now because of all the other research that's happened, that you don't have those natural history experiments. Are we too late now to have those sorts of experiments? Or are there other parts of the world where we could be evaluating patients who have had longstanding issues and then looking at arthritis backwards? I guess the case control style of study. I'm presuming that the field is thinking about this issue, because that would be the issue that you're looking as the driver for why you would want to be aggressive.
So there are osteoarthritis initiative cohorts around the world, which one could be actually looking at and tracking the morphological abnormalities. We tried to do that in our own little hospital.
Yeah.
All the hip replacements that have happened over the last 12 years and how many of them had actually got morphological abnormalities. And the percentage is quite high. But the thing we'll struggle to do there is get their genetics as well. So one can look at morphology influencing arthritic change and then leading to a joint replacement, but difficult to get genetic data. That will have to be prospective.
Understood. Yeah. I think there's a question, a comment from Oliver.
Yeah, and it's also very complex because we talked about the torsion of the femur, the torsion of the tibial. There are so many things around it. Genetics plus morphology of the hip, but morphology of also of the lumbar spine, the pelvis, the femur. This is why the more you know, the less you understand.
And the more humble you become, I think, Nico.
Yeah.
Absolutely.
I think Oliver wanted to say something. I saw you done.
Yeah. And there is one step forward with this complexity in the hip. From my point of view, there is a dissociation between the clinical and the radiological stuff in the hip. And it's very, very clear when you see a patient with a huge deformity and osteoarthritis and no pain and practicing some sports. So for me, this is also a big question, why these patients with so great osteoarthritis can do these sports. So we are not operating x-rays and we are operating patient, and this is another problem with the hip.
Lovely. Is there any other comments on the panel?
Mo, what's I come back to you, Mo.
I think Sunil and maybe Thanos wanted to speak. Maybe just
Thank you.
I was just going to add basically that even though knowledge is evolving, one area that has definitely evolved and we know more now is who not to operate rather than who to operate properly. And this is a big gain over the past few years. I mean, we know about the borderline dysplasia now being a gray area, et cetera, et cetera. So I think, and Vikas also highlighted that. He gave us more information about who not to operate rather than who to operate.
Thank you. That's a good point, Dennis. Sunil?
Yeah, the other thing is, as a fellow learning and going forward in hip arthroscopy, you think, okay, how much do I take off the cam? And we've seen, residual cams is a big issue. Again, so going through the learning curve, getting through the 150 cases and, getting better at your complications and then your traction time, and that's important. And what if, what would the panel say if someone like me went and set up a unit where from fresh, we all know about mentored practice, but if there's no mentor in the hospital, so how should one go about doing hip arthroscopy?
And that's a whole new question. Yeah, I don't know. Anyone else want to take that?
So luckily you're in a place where you will be in a mentored practice wherever you land up. So you'll be absolutely fine.
No, it's just, there are other people who may want to try out. So what would the panel suggest? It's an interesting question. Difficult.
I mean, technically, all of us, Sunil, have started like that. Whether it was Nico, myself, Oliver, all of us have started individual practices, and build it up. And I'd go back to the basics. I'd do a good young adult hip fellowship, I'd certainly go and see the top of the top surgeons around the world to refine my technique. And then in the first few places, I'd certainly make sure that I have somebody coming over to help me with those cases. And that's how I develop it. I'd spend enough time on the cadaver. And luckily now you've got the joys of a virtual reality world as well, and spend some time on the simulators as well. So I think you've got enough evidence now that if you did all these things, you would be able to start a practice in Timbuktu if you wanted to, for sure.
Well said. Well said.
I would like to add something because this is their surgical skills. But for me, the key is when to indicate or not indicate this surgery, because you can get the skills if you train, but it's more difficult for me to choose who will benefit from this surgery. And this is sometimes is a gap. When you visit someone, you don't go with him to the clinic. And for me, it's so important to go there and see the indication.
Yeah, I always say that going, going from good to great, it is a skill. You need skill, right? And you get that skill. But the great mentors and the great going from great to exceptional, it's all decision making. And so you have to have the benefit of mentorship, collaborators, peer-to-peer mentorship at some point, where you learn ultimately about decision making. As Stano said, when not to operate, and as Vikas says, and all the other panelists have been saying, what are the elements of staying up to date, learning, evaluating your own data, and then moving forward. But all I can say is that 1 hour flies by, and we can speak for 2 more hours, and I would love to, but unfortunately we have another session starting relatively shortly, so we'll be preparing for that one. I urge you all, though, to continue to do the work you're doing. Congratulate all of you for the work you're doing, and certainly those in attendance. Look up these individuals and some of the work that they do with respect to understanding the evidence. It's such an important issue. And maybe I will leave the last comment to our keynote this afternoon, this evening, Dr. Khanduja.
Well, my only comment would be, honestly, what would a person like you who sees it from a third person point of view advise a group like us who are keen on generating the right evidence? And you can clearly see the pitfalls in the evidence that's all out there. So what would you suggest, actually? That would be my last comment.
Right. And so, the only thing I would say is you've pretty well answered it quite eloquently throughout this discussion, which is keep moving forward, weed through the noise. The noise is going to be there, and you have to weather the storms and the discomfort of this feeling of, we take a few steps forward and then something comes out and we have to take a few steps back. We're always in a bit of a defense mode with some groups. We have other groups who are pushing too far and we've got to bring them in. There's all of this happening because this is a rapidly innovating field, and we see that in other areas. But usually, ultimately through the dust, through the noise, the signal will rise. And I think this evening I've been witnessing the pioneers in a way of evidence for that signal. So I just congratulate you and appreciate the fact that you're spending some time educating me a little bit about those issues. So not sure I answered your question, but all I'm saying is keep going.
Well, thank you very much for having us. Thank you.
All right, everyone, thank you so much, and have a rest of a great evening. Thanks so much, everyone.
Thanks a ton, everybody. Thank you.
Bye.
Right.
Thank
Good
you.
evening.